Since you mentioned alkylating agents, let's use that as an entree into transplant. We keep trying to get rid of transplant, but no success yet. Saad, there's been some publications recently from the French in particular, looking at whether you can delay or not do transplant at all. Can you summarize for us what those showed?
Sure, absolutely. So this was the Dana-Farber IFM study, but the French portion was accrued quickly and reported out. Dr. Tal just published it in New England Journal of Medicine, comparing early versus delayed transplant after RVD induction. And there was statistically significant and clinically meaningful PFS benefit in favor of early transplantation from the PFS standpoint. The overall survival at the follow-up time point at 4 years was no different, but I think that for most transplant trials, you have to wait out 5, 6, 7 years to see that overall survival curves separate.
In this trial, MRD was performed. In fact, it's one of the trials we have that shows that MRD is an important prognostic factor, right? Do you think it's changed your practice at all, or this was our standard NOE?
I think it was confirmatory evidence of the role of autologous stem cell transplant. I think it is, if you can tolerate it, it should be one of the major tools for newly diagnosed patients.
So I think it's important, though, that because I agree with you, that I think it does confirm the role, but many in our field say it confirms the exact opposite, that it says that you don't have to do it up front and that you can delay it. But I think the important point, and again, I agree with you. I think the important point is that if you look at MRD negativity, 2/3 of the patients that were MRD negative were in the transplant group.
Twice as many in the transplanted group as the non-transplanted, and they do better.
So I think if you want to roll the dice and presume your patient is going to be in that group at 18 or 24 months, that's a risk you take.
Yeah, absolutely.
I agree. I think that when you have that conversation with the patient, you want to pick the choice that gives your patients the best chance for getting into a deep remission and MRD negative, and that's what you get with early transplant.
So the Stamina trial, which has been presented, and not published yet, I don't think, compared a single transplant with a tandem transplant and a single transplant with consolidation, with the aim, I guess the hypothesis that a deeper remission would result in longer progression-free survival, and it didn't really seem to show that very conclusively.
It's just a little bit early for that trial to have reported, like about 5 years too early. And so when it's had adequate follow-up, it'll be a really good study. But currently, it's premature.
Any other people want to comment on the Stamina study? And as I recall, there was a slight advantage to tandem transplant, 4 months, and to consolidation, maybe 3 or 4 months, but not spectacular. So
I mean, I think the presumption there is that if a little melphalan, meaning one transplant, is good, then doubling it is better. And I think the reality is we have better drugs, we do better consolidation, we do better maintenance now. So I think we
anybody doing 2 transplants routinely?
Absolutely. So I think in the last year, the evidence is starting to mount up the superiority of the German compared to the Dutch in the EMN study.
Because it's done in Europe.
The EMN consolidation.
All right, we're going to gang up on you here. Anybody else? No. Okay, 5-1. You're defeated.
I feel like kind of you, mate, in a match against Real Madrid.
Okay. Let's talk about a couple of other abstracts from this meeting that we're at here in Chicago. What about chemotherapy? There's a couple of, a German trial in particular, looked at the role of Doxil, lenalidomide dex versus bortezomib, lenalidomide dex.
I mean, my answer would be if you use chemotherapy as part of your induction, you probably need a second transplant.
Okay.
So, so it's a good study. I mean, the regimens were relevant when the study was designed, but the combination of Velcade and Revlimid and Dex, which would you rather use with less toxicity?
Yeah, I think we have to remember that outside the United States, that giving those 2 drugs together, lenalidomide and bortezomib, is challenging, and this offers an alternative, I think, in some countries.
I think so.
You've been pretty tough on cyclophosphamide, Dr. Lonial. You never use that anymore in your newly diagnosed patients?
Not in newly diagnosed, no.
Does anybody use cyclophosphamide?
So we will use cyclophosphamide specifically in patients that have renal failure. And so our typical regimen is from the Mayo Clinic, the CyBor-D regimen, of bortezomib, cyclophosphamide, and dexamethasone. And we will do that until their creatinine clearance or their kidney function improves, and then we'll actually switch them over to the IMiD-based therapy.
I would say we do the same, and then there are patients who they're sick enough, you don't want to wait 2 weeks to get lenalidomide as an outpatient, and they're in the hospital, or maybe their insurance isn't very good. So there's still a percentage that we still use it to.
I would say that most of the patients that we start in the hospital are started on Sagar D
So
for the reasons that were mentioned.
Yeah, if they start in the
hospital.
Right.
In the hospital.
So you're outvoted, Dr. Lonial. I'm sorry.
Our data speaks for itself.
All right, there's another abstract here. We want to just quickly talk about the Forte trial from Italy. It looks like KRD versus KCD. Anybody want to comment on that? And that would be carfilzomib cyclophosphamide or carfilzomib lenalidomide up front.
I'm not fully aware of the results, but I would go with KRD.
So if I remember correctly, the depth of response was superior. The VGPR rates were north of 80% on the KRD, whereas they were around 65% with KSID. I'm not sure about the PFS benefit. It wasn't reported in the abstract, but it does appear that the IMiD-PI platform provided better depth of response.
But so it sort of comes down to what Keith was talking about. It's about health technology assessments and the issue of reimbursement in Europe. But when faced with an even choice, the imid-proteasome combination is
yeah. My take on this trial was that the cyclophosphamide arm was slightly less efficacious than the lenalidomide arm. But if you're in a country where you can't pay for both those drugs, cyclophosphamide carfilzomib performed pretty well.
Yeah.
It was just marginally less efficacious in terms of response rate. We don't have any PFS data yet.